I think that in order to start this roundtable, we actually have the most innovative topic of all. And I probably would like to say that this roundtable could stop right here, because if someone will tell me that tomorrow the supplementary insurance providers and patients will not have to contribute more, this will be absolutely impossible. So I think that the question right now is how you would like to participate in this process and what is the role that you would like to play in this process. I think that it actually goes through something that is important in the role of each and everyone, especially for you, Magali. And this is the way of knowing what is the role that you want to play and how are you going to play as a patient or as a partner, let's say a stakeholder from the healthcare sector, or are you going to be a different partner, because each role will be completely different, and so it will allow us to see how exactly we can see ourselves in the system that did not evolve for the last 30 years, but how can we probably foresee something innovative in this sector with different roles, different per stakeholder, I would say. So how the patients will play this role? Well, the patients are not playing anything, because they are basically suffering from diseases, and they're having this burden on them, the burden of the healthcare, and they are also very much associated, very little, associated to the decisions that are imposed on them and that they have to suffer from. And starting from yesterday, I have actually heard many different elements that allowed us to come to this round table and to focus on a key element, which is basically the role of the patient and the participation. So the awareness, the increase of the responsibility of the patients, I would say, and that's a topic that actually tackles many different subtopics, and it also talks about this strategy of the transfer of the load and the increase of the load. And Thomas has already said it. Well, we have this 7 billions of 13 billions of deficit, and probably in some years it's going to be 40 billions. So we actually no longer have the time. We have to react, and very often we say it in the central directions and so on, that it's not just to create decreases so that to increase the charges, but to find something that will be very efficient and as beneficiary as possible, as profitable as possible on the short run. We also have mentioned the figures yesterday, and I would like to go back to them because they are very much related to the roundtable today. We have been talking a lot about the obesity, the ALDs, and so on, everything that it represents in terms of the healthcare costs. And it has been said wrongly that it actually represents 75% of the healthcare insurance. Well, this is false, because I believe that this is around 68% of the expenses of the insurance, health insurance. But we actually have to look at the exoneration of the moderator ticket, and to look at the tools that we have are approximately at 15% of the health insurance. But we have to pay attention here, because all the figures are not the same, and they're actually related to different things. We also have this feeling of something being given for free, this health that is being for free for French and so on. I also think that this has been mentioned, but this is wrong, because the French understand that health costs them something, and it actually costs so much that starting from yesterday, a lot of people has already said that France is basically struggling with the social money that is given socially, and we actually understand that the patients aren't happy because they are paying too much. So it does not work anyway, and patients as well as the associations of patients are completely opposed to the increase of the amount to pay. And also what we are trying to do here is to probably somehow fix the ALDs, because despite the fact that we have already been talking about all of this, well, the very core of this health insurance, and the French are appreciating very much, because this is a unique characteristic for France, and it's actually very beneficial when someone has this chronic disease or very long-term disease. But with the ALD, we actually have 800 euros for people who don't have the ALD, and 500 euros in charge that have to pay people who do have ALD. But we also understand that complementary health insurance has increased increased as well. Well, it can increase of 6 to 10% for 2025 and 2026. So all of this is also a cost. And I'm not talking about all the invisible costs that are not mentioned by the public statistics that are also a heavy weight on the purchasing power of all the patients. So I would like to say that yes, today this is absolutely clear that absolutely everyone has to make efforts, because we cannot try some additional means, or probably not to look at this problem or to pay for expenses that are not necessary. We cannot allow ourselves that today. So everyone has to make efforts, but we have to be very attentive here, because the red line for us are the rights of the diseased. And our system right now allows us to take care of these people, and it should continue allowing that. And today at 9:50, we shouldn't be thinking about the explosion of the social pact and of the demolishing of all the values of solidarity that allowed us to create the health insurance, because, well, I believe that the catastrophic scenarios should have the impact, because they have to make us act, but they don't have to destroy absolutely everything, because this will be absolutely dramatic. And the healthcare system that is doing the privatization for the expenses are very expensive, but the solidary healthcare system costs much less. We understand this, which is why we have to save the health insurance and the principle of solidarity. And we also have to increase the responsibility of all the stakeholders, but it does not mean that we have to make the patients pay, because they are not responsible of their disease, and they shouldn't be held responsible for this burden that they have to carry. They shouldn't be burdened with the consequences, and especially given that this disease already impacts the quality of their life, but also the quality of their work. So we actually have to think about the values that we would like to promote through all of these signals and maintain through all of these signals. And once again, here we are talking about all the projects of the state and of the decrees that are talking about the increase of this fees in charge of the patient. So with respect to all these complementary health insurance bodies, what is their position, what is the type of contribution, and how exactly did you plan the added value for the system that you're going to bring to the system in the upcoming years? Because, well, if we are trying to avoid the increase of all this mandatory fees, how are we going to manage all this? Well, I would like to say that I have been invited here as one of the representatives of the complementary health insurance. So we have approximately 10% of the market, but we are not magicians here. I don't have a magic wand with me, I don't have it in my pocket, and we have to keep in mind the fact that when we're talking about the complementary health insurance that will be contributing as well and financing, the role of the complementary health insurance is to organize the mutualization of the fees, but the money is coming from the people who are basically paying all of this. So the question that we are asking ourselves, and Magali was saying that the patients are suffering, but the complementary health insurance is basically suffering as well, because we don't have any dialogue related to the financement. And today, the functioning of this complementary health insurance is to look at the evolution of the expenditure, to try and modelize it with all the current statistics, so that to foresee something for the future and to make the rates evolve accordingly. So I would like to say that the controlling authority in France that is controlling all the insurance companies is confirming that we are not earning any real money. So the most important thing here is to anticipate things, and if the expenses are going to increase, of course the rates will increase as well. And the indicators of this increase of the expenses is pretty much the same thing as for the Social Security in general. We have the aging of the population that is here. We also have these elements that are also appearing in the convention, and of course all of this also has an impact on the refunds by the health insurance and complementary health insurance as well. And beyond that, we also have the effects that can be complementary as well. For example, when we have the evolution right at the limit between the Social Security, the health insurance, and the complementary health insurance. And just to quote an example here, is that, well, if we have 30 to 40% of increase, of course, on one hand, it will be a saving, but on the other hand, finally, this will be still the same amount to be refunded. So the fact that the complementary health insurance must rebalance their accounts is creating additional issues and additional questions for the expenses of the complementary health insurance for some members of the population, but this basically still boils down to all the economical issues and the situation that is much broader than that. So the questions that we have to ask ourselves is about the money, because the money coming out of the pocket of the complementary health insurance is not there by magic. It is financed by solidarity, by this mandatory social security, where everyone is, where there are actually many different sources of financement. And we also have this complementary health insurance, where we are here talking about the mutualization within the population, whether this is for the population that are entrepreneurs or retired people or others, and we're basically mutualizing all of this. But finally, this mutualization allows us to somehow manage the situation and probably to displace our focus on the complementary health insurance is a trend that we have been noting for a couple of years now, but the consequence here is that the costs of the complementary health insurance are increasing as well. And finally, this is also the impact for the patient. So I would say that this is also a part of the national wealth that is dedicated to the healthcare system. So for me, the financement should be either through the mutualization, through this complementary health insurance, or through the solidarity of the mandatory health insurance. And for the complementary health insurance, one of our jobs is to try to modelize everything so that to adjust the rates, but at the same time, it's either our profession through the federations that has to assume the role that will be a little bit more explicit, either in terms of prevention, and we have been talking about this before, or fighting against fraud. And we actually have a group that is very present, that is convinced that we have some things to do here. Well, it does not really mean to save the system, but probably to do some savings, and this will be very positive if we are working all together. So it's pretty much the vision of a midterm and also the real dialogue, and today we are talking about these adjustments that we have to face, and more or less later, all of this will be adjusted, and it will also include the consequences of all the decisions that have been made, and these consequences will affect the patient as well. But concretely, beyond the purely financial role, are there any projects or partnerships that you can create all together? Partnerships probably that will be creating some additional values for health, because I know that you're very much interested in the question of prevention, you particularly representing the patients, but you also the complementary health insurance. But when we're listening to Thomas Batom, we understand that this is one of the major points here. So we are basically spending our time looking for all the different prevention policies that are very different and heterogeneous. And we also have these specific examples. And I will give the floor to Catherine about that a little bit later for the dentists, because we have things that are happening that are absolutely stunning in terms of fraud, but also in terms of prevention. And this is also a certain form of a project. So what I'm interested in is to know, what are your common proposals? How can we make the system evolve beyond the traditional stakeholders that are already very well known, meaning the healthcare professionals? So to talk about it, well, with pleasure. But Catherine, first, thank you very much, Elisabeth Hubert, for finally having done something for the dentists. I think that this is unprecedented. Nonetheless, the general health is impossible if we don't have the dental health, because this is crucial, and all the treatments that are provided by dentists and by dental surgeons Probably sometimes there is a small discrimination between these two professions, but they're crucial for all of us. So my profession was anticipated very early because at the end of the 80s, we already had some acts that have been admitted, acts about the oral health, the prosthesis, but also the orthodoncy, because we didn't have means to continue financing it, or the evolution of the costs for the offices of dentists, because 70% approximately of all the expenses are paid from the money that is perceived by the doctors, which is why we are not the sector 2, and we actually have these 2 branches or even 3 branches. We have the care that is offered that is completely opposable, because we have the prevention acts, but also the acts that are really charged, and 60% of them became also with a fixed cost. So we also have some essential acts that are the third part that are not refundable today. And here we are talking about the implants, for example. And starting from the 80s, our profession has understood that if we wanted to give the access to this care, we had to use the complementary health insurances so that to make it solvable, to make it payable. And at the end of the 80s, we have signed the protocol, which is called MOJAISKY protocol, that was about that. It was very easy to implement because we actually had just one interlocutor and just one contract. We will be going back to the current difficulty when we're working with complementary health insurances. But this protocol, MGUN, had some issues, judiciary issues at the very beginning, but this protocol was a pioneer protocol because we had this capping of the fees, and we also had to work with the mutuality and with the insured patients, and it made sense back then. But this was a pioneer of 100% health, pretty much, I would say. We actually had a couple of bugs on 100% health concept, and I will also talk about the prevention later. But we were the pioneer here, and this is something that exists for 27 years like right now, because this was the convention of 1998, and it was a convention with different modalities per age, and it was integrated into the law. And today, this is part of this tool, Génération Sans Alive, that we have defended, and we're very much attached to it. So this is our important debate, and I will explain to you why. Why right now this is facing a lot of problems, because the intervention of the complementary health insurances that could be an important additional plus here is actually breaking right now, because we have a problem with the complementary part, because we have the third party that must pay all of this. So this was a very important progress at the very beginning, and I would like to say that for our profession it was important, apart from the capping the rates that have been free before that. And I would like to say that at the level of the trade unions it was not easy at all, because Magali has already said that it was important to protect the trade unions, and I have been negotiating this program 100% health, 100% santé, and I can tell you that this was very complicated, not easy at all, especially me being a woman. And I would like to tell you that the problem to access the care, to access the treatments such as prosthesis for teeth, it was a big problem. And this is also the reflection of the social behavior, on the social behavior of the patients, because they could not smile, they could not work, because they just could not show their smile to everyone. These people felt very bad without teeth. So financed by the complementary health insurance, well, on paper it was 700, 800 million euros, and in practice it was actually much more expensive. And we have to understand that the complementary was a little bit luxury for us when we negotiated the next convention, but it was a true access to care. But we had to go through the responsible contracts, and this does not does not cover all of the insured. It only covers those who are having a salary. So those who don't have complementary health insurance are not affected by all this, so they have stayed at the margin of all this. And I actually have seen people who had these old contracts that did not have the courage to go and change the type of their contract just because it was very heavy in terms of procedure, and they could not access, let's say, dental prosthesis or something like that. So this was the major bug of this 100% Santé 100% Santé, 100% health program, because it was not integrated into it. And this was part of the demands that we are right now formulating to the complementary health insurance companies, because we would like to have this additional protection that is also granted to everyone. And also the prevention is an important point. So this prevention is something that we definitely love, and this is our DNA. This is something that allowed us to improve in a very considerable way the state of health, dental health for the young generation, and we have many elements that are proving this, but we also have some social markers on the health, dental health. We also have offices in some areas where we no longer have caries for the young generations, but in some other places we actually see that, well, we have some practitioners that are saying that sometimes people, children, 6-year-old or 7-year-old, are consuming too much sugar and they're coming with a lot of caries. They have absolutely no notion of the prevention rules, but the dental prevention is something that works. Starting from the beginning of the year, we actually were given, and I think that it actually started 2 years ago, the increase of the moderator ticket. And I would like to say that the parliamentaries have voted for this transfer to the AMC, but in June we had Thomas Faton, who announced to us this very small detail, the 300 million of the transfer. This will be done on the dentists, so on the dental surgeons, because only the acts that are in majority carried out by the dentist surgeons are being concerned by all of this. So we are actually feeling as we are being stigmatized here. So we understand that this is a moderator ticket, but starting from the very beginning of the year, the parliamentaries have also voted for the financement of the health insurance, the introduction of this moderator ticket for the prevention as well. But the prevention has already shown the proofs that it works. So we understand that right now, for us, this is a moderator ticket and also the third-party payment, which is mandatory as well. For the guarantee of the payment, we have already introduced this element, but in the field, it does not work. Some of the practitioners are doing this, but it has been delegated to the private operators because the parliamentaries have not foreseen the modalities of the functioning of this third-party payment. And we actually have also seen that when we wanted to do it in a generalized way, we have been denied it by the institutional council, because we didn't make precisions in terms of how this should work. And right now, what we're fearing is that people, the doctors, will stop doing prevention. They will continue treating patients, but they will be doing it through consultations or some other treatments that will no longer need the third-party payments. And the EBD that also had this very interesting parameter here is that the online data entry of all of this data, of the patient data, allowed us to talk about the evaluation and the follow-up. But we were using the tool Amélie Pro for this digital data, and it actually should have allowed us to see the results of all of this prevention methods. But right now, I fear that we will no longer be able to see these results. Thank you, Catherine. So, Philippe, the word is, the mic is yours. Yes, I have been listening to all of these interventions, and this was a little bit technical, the last one, I'm sorry about that. But, well, this is pretty much the debates between what the law is doing and what the regulations are doing, so I believe that we have to sort out between everything and give the possibility of acting to the politicians and also make them have them accountable in terms of their commitment. So from the point of view of the patients and also the complementary health insurance, this is still this big question for tomorrow, whether we will continue to do this prevention. But at the end of the patient is basically paying. Either they're doing it directly or indirectly. So if it's indirectly, it's because the complementary health insurance is basically collecting this money, but we also have the taxes that are here. So as long as we stay in the system and we have this analysis and we say that we have this fees that we have to pay and we will be trying to get this money from everywhere, if we stay in this position, the system system is basically facing the wall. And I have seen the PLFSS at the very beginning because it was a part of my work as well, and it was happening in front of me in the Senate. So I was able to see all this work that was carried out by all of our partners and all of our administrators. We were reading all the reports and we were trying to formulate the important idea that can be the base for us. And so we are moving forward, and we were taking the calculator and we are saying, so what is the total sum? And every time we cannot meet this goal, even imagining all these different efforts. So starting from there, we are completely changing our point of view, and we are asking, who will be paying for that? So this is how it happens. And starting from there, we will have the moderator ticket or this complementary health insurance that will have to pay a couple of billions, and we will have some taxes. And tomorrow, well, I would like to say that this is the type of the reasoning that we are having here, but this should not be the common reasoning with all of the stakeholders of the healthcare policy. Well, I am a parliamentary, so I know about the complementary health insurance of the mutualistic approach. So I know that there are some agreements that have been created, but then finally, at the end, we have to define who will be paying what, and the margins are decreasing. So finally, today, we are not having this role of an active actor, but of someone who is suffering the consequences. So yeah, of course, we are voting, but this is pretty much deregulated. So we have a decision that will be made. So it's not really the participation in the contribution, but how are we going to ask this patient to participate? What is the additional value, and how do we organize this whole process? That's the main problem here. So that's the same thing as about this financial topic. We have been talking about this prevention for the last couple of days. We have had this report in the Senate after the PLFSS on the topic of the prevention in addition to this. But what was shown here was that we had a number of stakeholders, and the sums that are dedicated to it today are absolutely huge. But we have many stakeholders, and because we lack a nationwide strategy, we don't have any steering. So everyone is doing what they can. So we have, of course, the political decisions and so on. But we are finally facing this situation where the efficiency of the money that has been invested into it is very small. Well, in terms of the collectivity that I already know, I see that, well, if I launch a project, I am trying to probably somehow follow this project of IRS, and I don't really have a concrete prevention measures. What is the strategy and what is the prevention? So we see that the stakeholders are too many. So you can be an older person staying at home, and then you will have probably two structures for complementary health insurance, for the prevention, and so on. So we understand that the debate is very real, but we are not using all the means of the partners, the patients, but also the complementary health insurance's opinion. So we have to manage it better. And I would like to make you react probably a little, because when I was looking at the last articles, the complementary health insurance was the first partner of La Poste, of the mail service, French national mail service. But if we just stop and calculate the costs of the operation and the introductions of the evolution, I would like to say that this cost is something that no company would want to invest in. And so that's an important debate. And this is also something going back to the topic that we have been tackling for the last 2 years, how all the stakeholders that all want to get a better quality, but have their own personal interest, can have a global vision and policy, each in their own branch, but also all together. I think that's the real debate. And for the PLFSS, well, of course, this was a preparation of a lot of different communications and letters. And everyone is writing to us, and whenever we are receiving the letters, we are reading all of them. And in the first part, we are actually explaining all the time why we need additional means. And there's the second line to say, well, we actually can do some savings. So people are telling us in these letters. So we're like, well, this is probably a new means for the savings. And the rest of the letter that we are receiving is that how can we do the savings in other branches? So I'm always just having these documents in front of me, and I'm trying to find some correspondences so that to see who is the better appreciated or less appreciated. And most of the time, the scapegoats here are the complementary health insurance companies, because they would say, yes, they have too much money because people confound very often, have this confusion between the financial results of the group, and they don't take into account all the obligations that these groups are facing, especially at the international, European level. So I'm not really defending them, but I believe that in terms of the prevention and some other things they should do better. But I think that this point of view is very biased in terms of how people perceive the complementary health insurance. So I think that, well, as I said, the prevention should be done better, but all of this requires some additional management. So you can see that for all the system, we have a problem of the global vision, and you have the essential point here, which is that the patients should be in the very center of all of these issues, because we cannot talk about the financial contributions without explaining the sense of it, and without explaining that this is not just the cost, because this is not just a problem of the invoice at the end, the cost of the disease, but all of the additional factors. So that's what I wanted to say, but that's a pleasure for me to take the floor. Magali.
Lâche-toi.
Go ahead, up to you. All right. Well, what I wanted to say today is that we have insisted a lot, and this is true, it's very important to remind ourselves the values that are gathering us around the health insurance, because they are important for all of us. But at the same time, and this is basically the result of it, in CAM we also have the AC. So we have this complementary health insurance, and we have this parity process. It's not like in the Netherlands. So we have this mandatory health insurance and complementary health insurance. So we have both of them. That's very important, because we have to keep it in mind and ask ourselves, what do we want to see tomorrow? Do we want to have a health insurance that will be refunding absolutely everything without the mandatory health insurance that will no longer be able to carry this cost? So that's the question, without even opening the debate on this big social security or whatever. So for me, the main question is that. So are we still working in the system that was created at the beginning, or do we want to leave this system completely? I understand that this question is not neutral, because, well, of course we have some exceptions, because we also have some fixed fees that are offered by the complementary health insurance, probably for some premium services or so on. But the principle today is the following. We have this offer related to drugs, but also different medical acts that are being covered by the health insurance. And from the moment they are being covered by the health insurance, they will have a rate that is also being taxable. And tomorrow, if we no longer have the health insurance refund, well, we will say that a drug at 15% of this rate will no longer exist. So what will happen? Well, of course, the price of these drugs will increase. This is absolutely clear. And here, who will be paying for that? Either the patient, that will have to pay for the drugs a much higher price. And here, a small parenthesis is that whenever we are talking about this empowerment and the increase of the responsibility, we are talking about the prescribed drugs. We are not talking about the impulsive consumption of drugs in the pharmacy, where a patient just decides to buy many different drugs. No, we are talking about just prescribed drugs. And I have been always looking for this figure that I was never able to find, is the number of the renouncements by the patients to buy the prescribed drugs because they don't have the money to pay the rest. And I have been talking to the doctors, and I actually have seen that this figure is huge. So if we are toward the disappearance of the refunds, the question is, who is going to pay for all of this? Because this is not free, and this is basically much more expensive for the global, for the patient in general. So this is the first point. Now, later, if we no longer have this C letter, I would say, this element of the social security, so we have this tendency that is basically here, that is kind of hinting at the possible disappearance of this social security, this mandatory health insurance element. But we are also sometimes thinking about, well, increasing the public expenses, and this will be just happening by magic. But we have to wonder, what is this mandatory health insurance? Well, everyone is basically given some money to it, depending on their means. That's how it works today. But this is not what happens at the level of the AMCs, because the prices and the fees that are given to the AMC are not indexed to the revenue of the patients, and this is major, because this is the determining principle, funding principle. So it's a social protection, yes, but this is not fair. It is not as solidary as the mandatory health insurance. And we have approximately 5% of people who don't have any complementary health insurance, without even mentioning the cost of the complementary health insurance for the seniors, who is not covered by the employers at all. So there is no employer part there. And also the additional complementary premium complementary health insurance that is offered by some of the employers. So I think that we have to be very careful when we're talking about these expenses. So it's not magic. It's not magic, and it's not relevant for the global savings in terms of health, and also for the access to care and for what the patient will have to pay. So we have this health insurance, we have the ALDs, and we have this early access, and this is something that is pioneer in France, but also in Europe. But we also have this country that has a lot of inequalities in terms of the access to the healthcare. So what are the complementary health insurance company doing for that? What are they offering today to highlight, consolidate, help these expenses and income in terms of the prevention? So what is the agreement that we can have with them in terms of the prevention? So what I'm thinking about is the association with the patient, because I believe that there is this important proximity. They know the problems of the inequality, of the problems related to the access to the healthcare. They have been working sometimes for 50 years plus. We have some associations that have dozens of years of experience about how we can develop this element and that element related to the healthcare. But are these associations, patient associations, somehow supported by the complementary health insurance? Well, I will be honest, we actually don't have a lot of time. But what I would like to say here is that I would like actually to make you react, but I think that in a reasonable way, going in the same sense as here, as you, I would like to think of all the questions that we have to ask ourselves. So what is the future tomorrow for the complementary health insurance organizations? Shall we continue with the same system with the increase of the fees, or are we able to somehow reform this model of the complementary health insurance? I think that that's the main question here, and to see how the complementary health insurance companies can become the true stakeholders, not just the contributors, but true active stakeholders in terms of healthcare. And for everyone, of course, the notion of the situation that exists right now, where we have to make a lot of efforts. But if I have to make efforts, I would use this term in terms of increase the responsibility of each stakeholder, and not just the efforts that are related to the financial contributions, but to responsibility. So I think that this is an important topic, but it has to be taken into account within a context. So we have to ask ourselves the right questions, but not just in terms of the reform. And I believe that this topic has to integrate global vision, but also the temporality, meaning the future. So we have to organize this debate so that to see who will be doing what, with which mission, and with which financial means. And I believe that we are not asking the same questions on the role of the patient within the healthcare system. So if we continue doing it as we did it already, we will be facing a wall, because the patient is not just a small element that has not a lot of sense here. We have many different stakeholders. Some of them have more money than others, but we have to create this dialogue that will be meaningful, this dialogue that will be completely different in terms of how we perceive the patient and what is the place of the patient in it. And to conclude, I actually would like to know how Éric would like to be part of this specific space, important space where we are rethinking health, because for 40 years we have been talking about the same thing. I'm sorry, but there's been 40 years, and right now we actually have to see how these things can definitely evolve. Yes, and this is probably also about the evolution of the complementary health insurance. Yes, healthcare is not just ophthalmologist or dental prosthesis question. Because all of this, oh yeah, and ophthalmologists, everything related to eyes, yes, that's also a big one. I actually wanted to hear the answer from Éric. Well, I actually wanted to talk about Humanis, which is a non-profitable actor that is also here in the system. And well, I cannot really express the position of the federations, but I believe that this C element that you have mentioned in A and C is very important for us, and I believe that we can be proud of the healthcare system in France because we are very well taken care of. And we also have the fees that are after the mandatory health insurance. So we actually have 3 points, we actually have most of the population that is being pretty much covered. We have some that is not, but globally the situation is quite positive. So the complementary health insurance companies are also working in this situation, contributing to this, and I believe that we could probably improve our efforts in terms of the prevention, in terms of fighting against fraud, and probably the prioritization of all the different treatments. But we are a little bit frustrated, our federation is a little bit frustrated about this topic, that we don't really have a common discussion when we also take into account our personal interests. Well, unfortunately, our time is running out, so we have to stop this very interesting discussion. Thank you very much.